One of the things that really resonates with our community is this pioneering spirit. I think it goes back over the decades and is really important to say that what we're doing here in so many different areas in healthcare is really a pioneering effort. So what is that? What are those factors? What have we pioneered in Utah, at the university, in Intermountain Healthcare that makes us different than so many places in the country? Well, one of the things that we know is that we've been able to figure out, using an accounting system, an activity-based accounting system, what it actually costs us to deliver care. Now, for those of you who balance your checkbook at home or run a small business or a large corporation, it may come as a shock, but we really, historically, have not known what it costs to deliver care. As strange as that may seem, as astounding as that may seem, one of the huge differences in the Department of Pediatrics and at Primary Children's Hospital and across the Intermountain system is we know what it costs to deliver care. And as a consequence, we can look very carefully at how we deliver care, knowing the cost basis. In addition, we've had an effort at Intermountain to develop care process models in a disciplined way, evidence-based way of delivering care. A couple of examples have set national standards. For example, Dr. Carrie Byington in the Department of Pediatrics, who is now the editor of the Red Book, the Pediatric Bible of Infectious Disease, completely turned around the way to think about babies less than 90 days of age who have fever. Historically, those babies were admitted to the hospital, given a series of tests, some of which were painful, and placed on antibiotics for 48 to 72 hours. Dr. Byington and her colleagues showed that using new technology, PCR technology, developed here at the University of Utah and formed the basis for the BioFire company, now can identify within an hour if a child has a bacterial infection or a viral infection, whether they need hospitalization or a dose of Tylenol and sent home to be comforted with their family. That's disruptive technology. That's disruptive and innovative ways of thinking about common pediatric problems. And I've heard one national leader in pediatrics say that if we were able to extend that across the United States, it would save $1 billion a year. We also have been pioneers and leaders in how we use our hospital resources. During the winter, many children get viral infections, and a few of those children, particularly babies, end up with respiratory syncytial virus, the so-called RSV virus. And 20 years ago, 10 years ago, the hospital was full of babies with that infection. Led by our emergency medicine physicians and our hospitalist physicians, we've been looking very carefully at how to manage those babies and have reduced the admissions dramatically. And for those babies who are admitted, the vast majority of them are out of the hospital in less than 24 hours. No magic medicine, no magic care, but an understanding of whether a child is going to get better or worse, and using hospital resources appropriately, and education of parents so that they can get their child home soon as possible and back into their family unit.